Hello, my name's Dr. Annalene Weston, dental legal consultant from Dental Protection. Welcome to RiskBites, a series of podcasts created specifically for dental practitioners in Australia. RiskBites looks at the key dental legal risks and issues affecting dental practitioners across Australia and provides helpful advice and guidance on how to steer clear of them, leaving you free to provide safe and high-quality dental care for your patients. Now, we're seeing an increased demand for cosmetic dental services right around the world, and many of you listening today will have noticed that your patients are more keen than ever to improve their smiles. Along with orthodontics and tooth whitening, dental veneers are possibly the most common form of cosmetic dental services being performed in general dental practice, as well as by specialist prosthodontists. And as our members perform more of these services, we're finding it quite commonplace to have conversations around the risks associated with that treatment. Indeed, in the past 12 to 18 months, the number of cases or complaints from veneers from our members in Australia has increased exponentially. So today we're going to explore some of the issues with these cases with one of our dental legal consultants, Simon Parsons. Hello, Simon.
Hello, Annie.
So Simon, if you were to focus on the most significant factor we see in complaints from patients about their veneers, what would that be?
I would call it buyer's remorse.
Now, that might be surprising to some of our listeners who may have been expecting you would say something about premature failures such as debonding or cracking.
I thought it might be actually, Annie, because we certainly see a significant number of cases where the veneer outcome has not been perfect. But if I was to try to get right to the root cause of the problem, I'd say it's far more around unmet expectations or changing expectations than the actual technical quality or durability of the treatment. While those clinical issues can feed into the remorse, it's much more than just that.
So can you elaborate a little bit about this issue for our listeners today, please?
Yeah, I'd be happy to. Psychologists tend to define the concept of buyer's remorse as a cognitive dissonance or an unease or regret after making a purchase. It's where what you thought you were getting is no longer something that satisfies you the way you expected it to. It tends to be more significant with large or expensive purchases, and often these can be associated with more significant regret. It hits us harder then. So perhaps you've bought a shirt and taken it home, worn it a couple of times, and then decided that you really don't like it. By now, you can't return it to the shop, so it goes to the back of your wardrobe and you tell yourself you'll never buy it again while quietly kicking yourself for buying it in the first place. Or perhaps you make the difference for the purchase. You take out a huge mortgage to buy a new home or a new practice, and you don't realize that you're actually under a flight path for the airport that could be 20 or 30 kilometers away. And you only become aware of that on weekends when you want to sleep in. And now you're worried about the capital growth that you'll experience during that ownership period because of being under that flight path. In that case, you're likely to really regret that decision and yet feel quite committed to it.
Yeah, and I guess veneers aren't like a trivial purchase, like an item of clothing, but also not as significant as a home.
Yeah, I mean, they sit somewhere in between, don't they? And I think both of those examples that I gave would be considered what economists would call purchases of goods. In reality, your purchase can be a physical product, a good, like a shirt or a building, or it can be a service. And I make that distinction because when we provide cosmetic dental treatment to patients, if I want to be really pedantic about it, I'm going to say that we offer both a good, in that we offer them a physical product in the form of a veneer or veneers, and we provide them with a service. And that's most likely going to be a transformation of that person's physical image and perhaps more importantly, their self-image. So I'd argue we're providing both goods and services when we do veneers on our patients.
Yeah, I don't disagree with you, Simon. And I think it's an important distinction. And it's interesting to think that Raj Ratan, our dental director, always puts a third layer on that too, and that being the layer of a credence good, which is a good purchased in trust or associated with trust. So why do you think it's important that it's both a good and a service?
I think it's really important because we've actually got to manage both aspects of that transaction then. We need to provide a high quality good, one that's fit for purpose. So in the case of veneers that look good, fit well, match the desired shade of the teeth in theory, and that don't interfere with the patient's occlusion or cause them any TMJ issues. And yet we have to make them look the way the patient expected them to look, whatever that might be. And that person wants to ultimately walk away feeling really good. So you might say that the service we are selling them is an answer to their hopes and dreams. And I think the two really go hand in hand, but the service aspect begins at the initial consultation and ends somewhere down the track after the veneers have been placed and you're doing the reviews. And I think the service part is very difficult, or at least a lot more difficult to measure or manage than what the actual physical product or the good is.
Agreed. And the relevance is?
Well, the relevance is that I suspect that most complaints about veneers actually arise when the patient looks in the mirror later, and that could be that day after they leave the chair or a week later. Or in some cases, like I can think of a recent case, Annie, where it's 2 years after the veneers have been placed by one of our members. Or it might actually be once they get home sometime and their loved ones or friends actually look at them and make a critical comment about their new look. And in cases like all of that, I think it's when the patient becomes aware that they're not as good looking as what they hope to be. And once they realize that, they essentially have that buyer's remorse. They have that regret for undertaking a procedure. Now, where it's really relevant is that these patients typically don't blame themselves for having unachievable goals or unrealistic hopes and dreams about what they might look like, but they tend to blame the person who placed those veneers and promised them that they would look like $1 million and who took thousands of dollars off them for that privilege.
So do you think the complaints are all about the money then?
No, I don't. I think it's about the emotions first and the money second, and perhaps any symptoms such as sensitivity or sore gingival margins third.
Okay, so what factors specifically feed into the financial side of this transaction then?
Well, I think a lot of people undergoing cosmetic dentistry, and particularly veneers, are in their late 20s to, say, mid-40s. I don't know if that's what you see, Annie. Either they don't have a lot of savings or they've been saving like crazy to afford to have this cosmetic makeover done. It might be part of a bigger makeover. And many of the cases that we get to see, as you know, are based on buy now, pay later schemes. So these patients don't have the money to have the veneers done right now, but they actually want the look that the veneers meant to give them. So they commit to a plan that might take them months or even years to pay off. And then each time when they look at their teeth, they regret still having to pay for something that they now realize that they couldn't really afford or hasn't provided them with the emotional value that they had hoped for. And they might realize at that point that they should have satisficed instead.
What do you mean by satisficed?
Well, what I mean is that what they could have done instead was that they could have gone for what we call something that would be good enough as an option. And that might have been something like tooth whitening or maybe a few composite veneers on just select teeth, rather than going the whole hog and having, say, 10 porcelain veneers. They wouldn't have needed to enter into this long-term credit arrangement of sorts, if that's what they've done. And they'll probably think that the results might have been as good or better, or at least offered them a higher level of perceived value for money.
Yeah, but it's not just this buy now, pay later cohort though. Don't you agree?
Yeah, you're right. I mean, I think what we're seeing really a lot now is this whole growth in the use of compassionate release of superannuation. And that's being used to fund all sorts of treatments, including veneer treatments from what we're starting to see. And in fact, we're seeing some practices encouraging patients to explore that option. Now, if people manage to access, say, $25,000 of superannuation, they might also incur tax liabilities at the end of the financial year. And once they start to contemplate it a bit more, they might realize that when they retire 20 or 30 years from now, or whenever that may be, that $25,000 that they've used on their teeth may actually result in them having, say, $100,000 less in their retirement savings. And then they look in the mirror and they think they don't look that beautiful after all, or as handsome as what they hope to be. And it becomes a major lose-lose for them.
Yeah, it does. Now, can I go back to the emotions you mentioned earlier? Why do you think a lot of clinicians go wrong with their veneer cases and end up with an intensely dissatisfied patient? Because we're seeing that a lot.
Here we are. And I think it's actually because they fail to diagnose the emotional aspect of the treatment. I think you'd probably agree, Annie, that most of us are pretty good at assessing the clinical components of the patient's mouth. We can look at tooth position and shape and color and vitality and their pink display and translucency, any of those other factors, and assess their current smile. But do we spend enough time on working out if the patient has realistic expectations or a lot of realistic or unrealistic emotional concerns? I don't know about you, Annie, although probably I really do. But I'm not that well trained in diagnosing a patient's psychological makeup or their emotional fragility, or even really have an understanding of just how much emphasis they're putting on having perfect teeth. And frankly, it's not something I really want to have to manage on an everyday basis.
Yeah. So do you think that's where some of the new breed of cosmetic dental clinics might be going wrong, that they're advertising a dream and attracting the dreamers?
Maybe. They're certainly good at promising a patient that there will be wonderful options available to them. And many of them, to their credit, are really good at doing a case workup. They take beautiful studio quality images of the before presentation of the patient. And again, with the after, they do their digital smile designs. They mock up the smiles for the patients. So they do all the basics right in terms of the clinical aspects of managing that patient. They get their patients to sign reams of paperwork sometimes. But really, do I suspect they really consider the emotional stability of the patient and the risk that those emotions will run rampant later on if the treatment fails in some way to deliver what the patient thought they were getting?
Yeah, and you and I saw a recent draft consent form from a really well-meaning member. But on it, they wanted to have each patient undergoing veneer treatment consent to, or to declare that they had already undergone an assessment for psychological suitability, such as screening for body dysmorphia. And I can understand why with the new ARPRA guidance. But what are your thoughts on that? Is this the magic bullet that we are all seeking, do you think?
No, it's absolutely not. And I think it's a well-intended means of trying to comply with ARPRA's guidance. But I think it really misses the point, because I suspect that most of the patients who really need such screening are the least self-aware of their condition and probably the most resistant to actually undertaking that. So for someone to insist upon them to do that screening might actually weed them out. If you're lucky, if that person resists and says no. But in reality, it's not necessarily going to create a safe environment to choose that patient to treat. I think they'll either make a false declaration, or they might try to fake some of the tests if you know how to do those tests. So I think it's one of those good ideas that probably doesn't really work well in actual clinical practice. And I think we're actually better off relying on our built-in radar.
And by radar, you mean our intuition?
Yeah, it's where I think some clinicians go wrong, though. They don't have a good radar. Perhaps they're very inexperienced and maybe a couple of years out of dental school, and they haven't yet developed that radar that we all take for granted. Or more commonly, for the rest of us, it might be just that the patient is a new patient who we haven't really gotten to know properly in order to form a reliable impression about. So it might sound a bit controversial, but I actually think new patients are perhaps the biggest danger to one's clinical practice, ironically.
Yeah, I don't disagree, particularly when you consider that most complaints come out of the first time you see a patient. So how do we build our intuition then around whether a patient's going to prove to be a bit of a nightmare?
I think we've got to take a bit of a three-pronged approach. I like three-pronged approaches, as you know. And I would say it's through experience, patience, and referral. So let's touch on each of those. We've talked a bit about experience, or sometimes a lack of experience in your radar, but I think the more you have in your clinical experience dealing with patients, the more you learn to listen to your inner voice and trust when you feel comfortable around a patient that you're about to treat. And you and I tend to sum up a patient within a few seconds of meeting them. And I know that we tend to do this by actually going out to reception and greeting our patients and talking to them on the way, taking them into your surgery. And not only do we do that sort of meet and greet because it's courteous and a really nice personal touch and makes the patient feel really special, but I think it also allows us to catch a glimpse of the patient when their guard is down. And our experience makes this an unconsciously competent moment in that visit. We don't actually have to think about what we're doing at the time. It just happens. And we read the room, so to speak, without really even knowing that we're doing it. And then if we're smart, we listen to those subconscious thoughts and feelings about this patient on this particular day. And we decide how we're going to manage that patient and if in fact we might need to offload them. So that's the experience side of things. The more we do it and the more we get to react and interact with our patients, hopefully the better we'll become at it, building our radar. But the second aspect, the patience with the CE on the end, is a bit different. We don't just jump in and do cosmetic dentistry on someone we don't know really well. We sort out all their underlying disease first. And then if we are, in my opinion, clinically smart and behaviorally smart, we get the patient to demonstrate a period of stability. And that's because we want to know if the patient can sustain their good oral hygiene, let's say, or manage their bruxism-related tooth damage and not have more teeth going wrong. So I guess what I'm alluding to is we delay decisions about treatment until that patient has had a period of stability and some clarity around what their expectations are. And only then are we going to do, say, a quick mock-up or provide them with examples of what's possible and give them printed supplementary information and encourage them to go home and think about it. And also, really importantly, consult their loved ones. And even then, I know I tend to recommend the least invasive and least expensive option first. And that's with a view to enabling the more complex or higher cost options to be done only if the first one doesn't satisfy us. Now, Annie, I know that some of our listeners out there are probably hearing me say that, and they're going to say, well, you know what? I don't particularly want to aspire in my clinical practice to suffice just to do what's good enough for my patients. I actually want to deliver the best possible, the ideal treatment for my patients. And I actually really respect that. It's a noble pursuit, and it's one that can deliver great professional and personal satisfaction and really build your practice. So I don't rubbish that at all. It's just that I feel that most of my patients, after 30 odd years of clinical practice, still don't really get, in inverted commas, exactly what I can do for them, no matter how many consultations we might have had, until it's actually in their mouths. There's no substitute for our patients experiencing things. Now, most of the time, I'm pleased to say they're delighted, and I hope that's your experience out there too. But if I need to change, say, the shape or color or length of a composite veneer, I know I can do that really easily. and really quickly and address a patient's concern. And that's so much easier than trying to do that with an Emax veneer, because if it's too short, I can't lengthen it and I can't change its color unless I remake it. So by satisficing, in a sense, and giving them what I think is going to work well, if I find that, say, a composite veneer doesn't quite deliver the expected beauty that the patient's after, I can still offer them a porcelain one. If I feel comfortable dealing with that patient, then it just keeps my options open. Had I just jumped in and given them the ideal treatment first and found that they don't like it, I'm a bit stuck. There may not be a lot of other things I can do. So that's the second way that I think I develop some more intuition, by working through these options with them and not taking them too far along the journey, and then reading them as they react to what I'm offering them and often doing for them. The third one is referral. And although it's the last one, I think it's actually the most sort of intrinsic to how we do thorough informed consent, particularly for complex cases. And I genuinely feel that all patients who are considering having veneers done, I'm not talking so much just one veneer, but certainly multiple veneers, will benefit from a second opinion, ideally from a specialist. And that specialist might be a prosthodontist, but it could also be an endodontist if it's to assess that single discolored root-treated upper central incisor, or it could be an orthodontist because the patient's got some mild or moderate crowding, could be potentially all three of them. And if you're already a specialist listening to this, then that may not really apply to you within your own discipline, but it might apply to those disciplines that you're not specializing in. Because what it's really going to do is help you manage a patient's reservations or doubts about what you've proposed as their cosmetic solution. So the example of that might be that you are a prosthodontist and you, as part of your provision of that opinion, you identify that that patient actually has poor periodontal health, or maybe a really thin soft tissue biotype, and you're worried about how their gingival condition will react to that treatment. So you'll refer them to a periodontist to have that checked as part of the assessment and case workup for that patient. So no matter what the circumstances are, I honestly believe a second opinion achieves a whole host of benefits.
Yeah, I agree. And it opens the patient's thinking up to alternatives, including, of course, the critical option of no treatment, or having ortho first, or only ortho at all, that type of thing.
Yeah. It also allows the patient to compare prices. And that's important because sometimes they think what you're offering them is really expensive until they get the specialist quote. Sometimes they need to know what the full cost of treatment is going to be, because if it is more complex than initially thought and will involve ortho and perio, they're going to have a lot more information to process and they might need to revise their budget. And it's much better to do that upfront than down the track. And it's going to help them really understand whether they're prepared to commit to treatment. It reassures them too that you're being really thorough by encouraging them to seek advice in case there's something that you might have missed. And I think overall, it really acts as a helpful screening tool about a patient's overall commitment to the idea of improving their dental appearance. And it helps us identify really how much that patient wants the proposed treatment.
So do you see referral as a hoop that all these patients should jump through?
Yeah, I do. I think for the vast majority of them anyway. I think if the patient is really committed to the idea of having a smile makeover, for instance, then they will jump through that hoop of having a specialist referral, because they'll understand that I'm only recommending it because I feel it's in their best interest to seek another opinion, and that it's too important an issue to get wrong. And then I get it wrong sometimes.
And I know you're also thinking that you're covering yourself in the process. Am I right?
Yes. Yeah, the whole specialist referral is not purely altruistic. I have to admit, I could call it a little bit rudely my CYA moment, if I'm allowed to say that. I know the dental board expect me to conduct a thorough consent process. And I know that in most of our litigated matters, the patient's lawyers will identify if the patient was never offered specialist referral prior to commencing treatment, and that becomes a real vulnerability for our members in defending a claim. So I see specialist referral as a smart tactic, and it ensures that I'm not just covering the patient's interest, but I'm helping to protect my own. It reminds me too that if the patient refuses to comply, it's an opportunity for me to then have the conversation about how I think I'm not the right person to help them going forwards. So it could be the sort of Clayton's psychological screening tool that our member was alluding to earlier for their consent form, because I think it will help us unpack some of the psychological barriers that patients may have or some of the hang-ups that they have. And this will be a bit of a critical moment in identifying if that patient is going to prove difficult later on.
Yeah, I don't disagree. So, Simon, a lot of our younger practitioners are really thirsty for clinical tips about veneers. So, do you want to throw some clinical tips into our discussion before we finish?
Yeah, I will. I'll keep it pretty brief though, because I think sometimes veneers are sort of such a big topic, and I know we've covered it in some of our publications that there's a lot that we could talk about. I'm going to start off by saying that I think veneers are arguably one of the easiest preparations we can do, but possibly the hardest thing we can finish off. And a lot of the time we can be tempted to think that because we're not cutting, say, deeply into teeth, that there's not really such a need for a preoperative assessment to be very thorough, especially if our veneer treatment is going to be additive. So we're just really increasing the bulk of the tooth. We're not cutting into it. But I'd actually argue that those cases are possibly the riskiest ones. And I've certainly had to deal with cases where the veneers have been additive, but for whatever reason, the patient's teeth have become really sensitive. I know that doesn't seem to make a lot of sense clinically, but believe me, it does happen. And in those sorts of cases, we've seen patients get extremely upset because they've been promised that this is going to be a really easy procedure and without any major risks. And the dentist hasn't really checked their teeth very thoroughly by the sounds of it. And the patient comes back and says, "You told me I wouldn't feel anything because you weren't going to drill my teeth and make them smaller. So why are they now so sensitive?" So I think if we want to avoid those sorts of awkward conversations, we've got to do really a multifactorial clinical approach. We've got to obviously take a really thorough social and dental history. We really have to take periapical radiographs and perform pulp vitality tests, even though the chance of vitality being impacted long-term is low. But we need to establish a baseline. And I'd really encourage you to think about doing that to the surrounding teeth outside of the treatment zone. And that's because we do get instances where we're dealing with claims about teeth adjacent to the region that's been treated that play up after veneers have been placed. And we've got members getting accused of damaging those teeth as part of the veneer treatment. And all of you out there know that that's almost certainly a preposterous assumption. But unless we can demonstrate that the teeth were or weren't healthy prior to treatment, it becomes very difficult to defend. I'd really encourage the clinician to do a perio chart, at least for the area of interest that you're considering doing veneers in. It seems that the dental boards see that as the gold standard, and it's something that we should aspire to doing. And if nothing else, it helps us assess the gingival biotype more thoroughly, and it may help us understand, how much danger is there of invading the biologic width and things like that here. Do I have any real soft tissue to play around with or not? Take plenty of photos, taken from all sorts of angles in different lighting and with or without makeup if the patient wears makeup, and with the lips retracted but also at rest. And make sure you take photos of the stump shades during the preparation without the teeth being dehydrated. The lab really needs that to create really good veneers. Even if you're doing composite veneers, I found that showing the patient what the teeth look like before I did often very minor changes and afterwards really brings home the cosmetic improvement that we've achieved. They just don't remember. I think you should always price in the cost of a night guard for a patient, even if it's a simple pull down type of one that you can make often in your own practice, and get them to actually start to wear one before you do, say, a whole set of Weston veneers. I think it's so critical because we see cases where veneers fail because patients don't comply with night guard use, but they claim that they do. So I think if you get the patient to start trying to comply with night guard use before they start on the treatment, if they're going to be resistant, you're going to weed those people out. You'll better tell. You get them to bring the night guard in and you have a look to see if there's any scratch marks on them. You see if they look clean or dirty. Sometimes a night guard will look brand new, won't they? And you're going to say, no, well, mine doesn't that I wear. It's a dentist thing. I think we sort of drive them into the ground. But we know that, a patient comes back with a night guard with no damage or wear or, any sort of crud on it, isn't wearing it. And they're probably not going to wear it later on. Now, you can make that night guard and you can get them to do a bit of tooth whitening and put some whitening gel inside that night guard to wear for a while. Now, I admit that they may not wear that at night, but it gets them on the journey to accepting that a night guard is part of their cosmetic makeover. And some of you are going to argue that it's not always necessary, and I'm happy to accept that. That's at your risk. I tend to make them for all my cosmetic patients because it's another box that I'm ticking. But it's one that hopefully means that if they still break veneers, I can troubleshoot why a bit better and maybe manage things differently. So I see it as another screening tool.
Oh, that's great. And if your patient has pre-treatment whitening and decides that's sufficient, please be very, very happy about that.
Exactly. Sometimes they'll be really delighted, won't they? And they'll go, do I really need those veneers after all? And that's sort of a fabulous place to be, I think, because again, you've done the least amount of treatment necessary to give the patient something that they are valuing and see as beneficial for them. So why wouldn't you do that?
Absolutely. So any final thoughts, Simon?
Yeah, I guess it's a bit hackneyed, but I think cosmetic dentistry of pretty much any type is going to be elective for just about every patient we see. So if you agree, can I really encourage you to not rush into agreeing to do any veneer treatment for a patient whose dental appearance has been the way it is perhaps for decades? Why rush it? We don't have to fix it right now. We can certainly explore what those options may need to be, but really take your time and encourage your patient to do the same. So explain that this has been a problem that may have developed over many, many years and that it's not going to be resolved today, but that it can be resolved if we put enough time into it to work out what the right solution is. And by telling the patient that it can't be rushed, hopefully they're going to listen to you. If they're after a quick fix and they have oversimplified what's involved, you're going to tease that out really quickly and really early. And you can reset those expectations, or if you can't, then you can refer them on. And I think that's a really critical thing to get right.
No, absolutely. Thank you so much, Simon. And thank you all for listening. And as ever, we hope this podcast was helpful to you. And we look forward to sharing more guidance with you in the future. If you like dental protection podcasts and you'd like to hear more, please subscribe and leave a review.